Why can't we move research into practice? Improving the uptake of proven evidence. First of all, what exactly are we talking about when we say uptake of proven evidence? Do we mean dissemination? Do we mean synthesis? Do we mean exchange, application, knowledge translation? These are all words that we've used in the past to reference when we share our research knowledge. Dissemination involves identifying the appropriate audience and tailoring the message and medium to the audience. So dissemination activities might include creating summaries for stakeholders, education sessions with patients, practitioners, or policymakers, or engaging knowledge users in developing and executing implementation plans, the creation of tools, or media engagement. Let's consider synthesis. Synthesis is the contextualization and integration of research findings of individual research studies within a larger body of knowledge on that particular topic. So if you consider a Cochrane review, for example, a Cochrane review will take all of the research that's been done in a particular area and synthesize it into one meaningful paper. Cochrane reviews are a good example of syntheses. Realist synthesis, narrative synthesis, meta-analysis, meta-synthesis, and practice guidelines are all forms of knowledge synthesis. What about exchange? The interaction between a knowledge user and a researcher results in mutual learning or knowledge exchange. So collaborative problem solving always happens between researchers and decision makers while creating research projects or deciding how to use information that's come from research projects. So that mutual learning process, through the process of planning, producing, disseminating, and applying existing or new research in decision making or policy creation, is knowledge exchange. How about the ethically sound application of knowledge? Activities for improved health consistent with ethical principles and norms, social values, as well as legal and other regulatory bodies constitute the ethically sound application of knowledge. We refer to ethically sound application of knowledge when we talk about research studies that are ethical and that the findings of those research studies are implemented in such a way that it is ethical for the society that is benefiting from those research findings. So what is knowledge translation? In the context of everything that's been described so far, the Canadian Institutes of Health Research defines knowledge translation as the compilation of all these things: dissemination, synthesis, exchange, and ethically sound application. So that's implementation, right? Isn't KT, knowledge translation, implementation science? No. Implementation research is the scientific study of methods to promote the systematic uptake of proven clinical treatments, practices, organizational and management interventions into routine practice, and hence to improve health. Research on implementation addresses the level to which health interventions can fit within real-world public health and clinical service systems. These two websites, www.implementationscience.com and www.fic.nih.gov, are excellent resources for implementation science. So what exactly does implementation science study? Well, here are some examples. Perhaps you want to compare two evidence-based interventions and see which one works best or saves the health system more money. Maybe you want to look at how to promote the use of evidence-based guidelines, because we know that evidence isn't being used the best way it should be. Maybe you want to adapt an intervention that's been used elsewhere to a different population. Maybe you want to look at how to scale up effective interventions that are already in place. Maybe you want to look at the effects of a quality improvement program. Implementation science studies the implementation of evidence that has already been proven to work. Why do we need implementation science? Why can't we just do the knowledge translation and be done with it? Because implementation is not knowledge translation in and of itself, and research is an iterative process. So let's complicate things by looking at a very complex knowledge to action process. As you can see, knowledge creation happens down here in the middle of the circle. So we have inquiry, we have synthesis, we have products and tools that we use for tailoring knowledge. But on the outside of this knowledge creation triangle, we have an iterative action cycle. So we will identify a problem, and we will adapt knowledge to the local context of that problem. We'll assess barriers to the knowledge use. We will tailor and implement interventions. We will monitor that knowledge use, evaluate the outcomes, sustain the knowledge use, and the whole process starts over again, as it should. If we're going to implement change in any system, we should constantly evaluate that change to make sure that it is always successful. The reality, however, in our current research environment is that we have these valleys of death identified by the CIHR. We're really good at doing basic medical research, but we hit a valley where that basic medical research isn't translated into clinical science and knowledge. Similarly, on the research to practice continuum, we're really good at doing clinical science and creating evidence and knowledge in that area. But we're really poor, valley number 2, in turning this evidence into clinical practice and changes in the healthcare system and health decision making. What implementation science aims to do is close this valley number 2 and take the evidence that we have from all of the great clinical science that we're doing and actually move it into practice so that it has an impact on patient outcomes and the healthcare system in general. We're not the only ones to identify these gaps. The National Institutes of Health identify similar areas of death, such as research to program death, where research evidence is not adequately or appropriately considered and integrated into the development of health outcomes, and research to policy death, where research evidence is not adequately or appropriately considered and integrated into the development of health policy. So why does implementation fail? The short answer is we just don't do it. We're really good at doing the research. We're really good at sharing that research with our peers and publishing in peer-reviewed journals and presenting at conferences. But we seem to fall short at the implementation phase. Preconditions sometimes aren't there. Any change involves people, involves attitudes around change, involves new training, which involves money, and also involves time. So it can also be very costly to implement research findings. It can be very difficult to implement research findings. And sometimes the research findings in theory sound really great, but just don't fit in the local context. How is implementation science going to make implementation actually happen? Hopefully by changing the way we think about research, who we do research with, and how we actually do research. Implementation science really is a new way of thinking. It's new, but it's a quickly developing field. For example, JAMA Pediatrics has just put out a call for a special issue for spring 2015 devoted exclusively to implementation science. Implementation science is a new way of thinking and certainly comes with challenges. Current studies and existing research are quite small, dissemination remains fairly local, and the scientific methods are loose. Another quality of implementation science is that it is inherently interdisciplinary and multidisciplinary. Implementation science depends on the collaboration between researchers, implementers, policymakers, and the public. It is an excellent opportunity to learn from each other. The challenges with this, of course, are identifying methods of bringing people together and communicating in a meaningful way in a similar language, developing common interests and common goals. Identifying the expectations of researchers and the expectations of those involved in the implementation of the new processes can be tricky as well. What is implementation science not? Implementation science is not your typically scientifically rigorous research. It opens up many opportunities to design research in a context that is locally relevant. The challenges with this are that research and funders will need to appreciate the value of findings from studies that are more loosely controlled than the scientific norm. Implementation research requires a balance between rigor and real-world application. This is why sometimes the methods seem a little bit more loose than the scientific norm. In this instance, we must acknowledge that rigor does not equal quality. Scientific rigor in implementation science has to be balanced with the need to conduct research that applies to real-world settings, since we will be implementing change in real-world settings. Researchers must also be open to a range of methods, including qualitative as well as quantitative, and methods that exist outside of their discipline. The Translating Research into Care funding opportunity is based on implementation science. To put implementation science in context, here is an example of a TRIC-funded implementation science project. Conducted by Ernest Snellgrove Clark and her colleagues, her implementation science project is called A Change in the Approach to How Women Push When They Are Fully Dilated, or Second Stage Management, has the potential to increase vaginal deliveries, decrease cesarean births, as well as decrease the length of hospital stays for mothers. In this study, Snellgrove Clark and her colleagues have taken an evidence-based approach called second stage management and applied it to deliveries at the IWK Health Center. The end goal of this implementation is to decrease the number of cesarean births, which puts mothers at risk, and to decrease the length of hospital stays for moms, which decreases the amount of dollars spent by the healthcare system. This is a great example of taking proven evidence, implementing it into practice, with the end goal being improved patient outcome and improved healthcare delivery. A second example of a TRIC-funded grant is by Isabel Smith and colleagues. This implementation science project is called Defining a Health Education Partnership for Earlier Identification and Assessment of Autism Spectrum Disorders in School-Age Children. The goal of this study is to achieve a more efficient detection and more timely diagnosis of autism spectrum disorder to improve academic outcomes for children. The implementation piece of this research will be an assessment program that identifies children early. This means that children have a better school experience, have better outcomes, and longitudinally perform better within the Nova Scotia school system. Funding for the TRIC program is provided by the QE2 Health Sciences Foundation and the IWK Foundation. This slide provides you with a variety of links that can give you more information about implementation science as well as funding opportunities that are coming up locally and nationally. If you have any more questions about implementation science, please feel free to contact me, Jill Hatchette, at jill.hatchette@iwk.nshealth.ca. Thank you.